Hello there, is it Mrs. Vane?
It is, yes.
Hello, my name's Geordie Morrell. Nice to meet you. I believe the nurses have come and asked me to come and have a chat with you.
It's about time. I've been waiting for somebody to come and tell me what's wrong.
Right, I'm really sorry.
They've put this drip in and
Yes.
they've muttered about an infection,
Okay,
but nobody cares, and I need to get home to my kids.
right. I can reassure you that we do care, and I'm really sorry that people haven't been explaining things as they've been going along. But if I can try and explain now what's been happening. So first of all, what have you been, from the little you've been told, what do you understand about why you're here?
Well, I've sort of had this temperature like flu and
Right.
over really the last couple of weeks.
Right.
And I was getting worse actually rather than better. So
Right.
I went to the doctor who sent me to A&E.
I see. So it's been sort of flu-like problems, aching joints, right?
Yeah.
Okay, and they've mentioned that
I've been breathless as well.
Yes, and they've mentioned that they think it's an infection. Have they mentioned whereabouts they thought the infection
No, they
was?
haven't told me anything like that.
Right. Okay.
Well, I'm really frustrated.
Okay. Well, they've from the blood test that they've done early on, I can see that your infection-fighting cells, the white cells, are raised, and that implies infection. There's also another test we do very commonly called a CRP, which just essentially tells me how inflamed the blood is, and that's again raised as it would be in an infection. They drew some blood, which was put into a special sort of culture medium where they can grow any bacteria that might be in the blood, and unfortunately that's grown quite a serious bug. So it tells me there's a bug floating around in the blood. Now, I understand in the past you've used drugs. Is that right?
Yes, I've used heroin a bit, and
Right.
I have been on a methadone
Okay.
thing to get off it, but then I was back on it again.
I'm sorry. Right.
And they've been giving me methadone in here.
Yeah. And was that injecting heroin? Yeah.
Yeah.
And were you ever sharing needles or using some?
Not usually, but
No.
I suppose possibly.
Okay.
I might have got one of my partners.
Right. He uses as well, does he?
Oh yeah,
Right.
he's a big drug user.
And sometimes people use like dirty water and things to dissolve the heroin in. Have you?
Oh, I don't know what you mean by dirty water.
Well, I know that some people have been in a position where they wanted to use heroin, but all they could find was a puddle of water or something like that.
No,
that's okay. Well, even so, every time I put a needle through someone's skin, it runs the risk of infection, and that's with thoroughly cleaning the skin and things like that. So when people are injecting themselves and not particularly going into the vein, that can really make it's a really high risk for causing infection. And I think that's the most likely reason for you getting this infection in the blood. And when people have an infection in the blood, that can infect anywhere where the blood goes to, and one of the key places where the blood flows through is your heart. And you may remember that they did an ultrasound scan of the heart called an echocardiogram, and that shows that there's evidence of infection on one of the heart valves, and that would
serious, isn't it?
It is, yes. I'm sorry. That infection on the heart valve would explain why you've been getting some of these symptoms. So the fevers and the sort of feeling generally unwell, I'd expect those from the infection floating around in the blood. But the breathlessness would imply to me that the heart valve isn't working very well because it's got this infection sat on the valve.
Will it get better with this?
Well, that's our hope. We know the bug and we know where the problem is, but it's a difficult infection to treat, and it's one that takes time. And by time, we're talking about several weeks of treatment through the vein.
I need to go home.
Why do you need to go home?
Because my partner is looking after the two children.
Right.
And they're only 5 and 7, and he's off his head most of the time.
Oh dear.
He's a big user.
Right.
And I'm not sure
You don't think
he
he's
knows
really
how to
right?
look after them. Yes, I have drugs as well, but
Yeah.
only I'm fairly careful. Well, I'm
Okay.
very careful.
Yeah.
Don't use very much, and I'm trying to get off it.
Right.
But he's really not suitable to
No.
look after.
Okay. Well, I totally understand, and I'd be worried in the same situation. My main priority here is your health, and
I'm
without,
going to have to stay in, aren't I?
I'm afraid so.
Well, I'm going to have to stay in 6 weeks, will I?
It depends on how the treatment goes. I can't give you but we are talking. It's usually several weeks of treatment. Now, that's my main priority is getting you better. But I do have strong concerns about what's happening at home, as you do, and that's something that we need to try and sort out. Now, there's lots of help we can provide. If you're worried about the
I
kids,
guess you mean about putting them into care.
that's one option, but it's not the only option. When children's safety is at risk, then there can be a bit of a heavy-handed approach, but that's really just to make sure that they are safe. So we go from the extremes that you've mentioned there of taking the children and putting them somewhere else where they'd be safe and well looked after, and that's, it's the extreme option, but it still maintains their safety, makes sure that they're well looked after. To simply just going around to the house and seeing what we can do to help, and if your partner's struggling but wants to keep looking after them, and you think that with a bit of help we can help him look after your kids, then we can do that. And there's various options in between.
We're not on the social services register.
Right.
If they get us on there,
Yeah.
we'll be in for a bad time in the future
Not necessarily.
with him.
I mean, we've got a duty to look after children. It's, even though they're not my children, I've still got a duty to make sure that they're being looked after. And so that's,
they're not being looked after.
Right.
He won't look after them properly. I mean, he might be around occasionally, but he'll leave them.
well, let's do something, and let's get them safe. Yeah. So we'll get in touch with the relevant people. It doesn't necessarily mean that they are, off with strangers. Is any family that's...
No, I mean, the family have washed their hands with us
Right.
of us long ago.
Okay. Well,
They wouldn't help.
there's lots of good emergency measures, and then if we're talking about a matter of weeks in hospital, and it can just be a temporary thing while things get settled
After
down.
these weeks in hospital, if it's cleared, it won't come back, will it? Should I be cleared then?
I think you need to knock the heroin on the head.
Well, I do. I know
Yeah.
that now, and if that's what's caused this, I mean, I have tried to come off, and I'm not a big user. I will come off because the kids matter too much.
Yeah,
but,
good.
But will that even so still be in my blood?
The antibiotics we're giving you are essentially the equivalent of domestos. They're going to kill the bugs, and they're going to.
It's a frightening thought.
It's not domestos.
No.
I promise that, the equivalent. So it's a good broad spectrum. We use the term antibiotic. So it's going to cover, and it's going to. You're going to have such a long course with it. It will completely clear the bacteria from your system. You mentioned if things go right, if it clears up, then that's right. It'll, and if we aren't putting more bacteria into your body through the injections, then there's no reason why it should come back again. But you've mentioned a point now, if it clears up, and there's possibilities of even with all the antibiotics, we may not be able to completely clear this. It's sort of a, they refer to it as a vegetation. So it's like a little lump of infection sat on the heart valve. So even with the antibiotics, it may not completely remove that. And that's why you need to be in hospital, so that we can, number one, give you the treatment, and number two, monitor how things go.
What if it doesn't clear it?
If it doesn't clear it, we might need to think about a surgery. Okay. And I won't lie to you, it's not a simple operation. Yeah, it is operating on the heart, and that's always tricky. But we've got experts, who do this every day.
I wish I hadn't asked.
But we're not there.
Dear. No, we're not there yet.
And I'm hopeful, but I think it's.
And then I've got to get my kids back from social service.
2 minutes.
But it's important that you know how serious this can be, and I don't want this to be a surprise for you. In a few weeks' time, when we say, right, we need to do something about that heart valve.
If I'm here that long, will you sort of help me to get off the drugs? I mean,
Of course.
you put me on methadone when I came in. What will you do? Will you sort of reduce that gradually, or?
People tend to stay on methadone as long as they need it. Now, coming off drugs, the methadone helps, but it's not the whole solution. You're the solution.
I know, yeah.
And a lot of it comes from your willpower, and you will tell us if you feel. Well, the aim is to give you enough methadone so that you're not having all of the withdrawal symptoms from the heroin, but it's not supposed to be enough to give you the sort of the euphoria, the positive sides of the heroin. So we're giving you enough to just to keep the withdrawal at bay, and gradually you'll come off the methadone. We can reduce the dose gradually, but it's a long process, and it's we do it by talking with you, and and giving you the support, and seeing how things go. There's not a sort of a recipe for this.
No.
Everyone's different, and you said you'd come off it before, and you'd managed on the methadone, but then you'd relapsed and gone back into the old ways. So I would be hopeful that we can do it a bit better this time. We can do it and just gradually come down, and you've got your kids as a reinforcement there to say, that's why I'm doing it. And if you need a photo of both of them, their bonny faces, to remind you that that's why you're doing it.
Excellent. We'll stop it there just in the interest of time.
Thank you.
Okay, Dr. Morrell, there was lots of issues there, clearly, and you dealt with lots of them as you went along. Certainly the one about her children at home, I just wanted to dwell on that. You mentioned social services and all the various options. Yeah. If she asked you not to get social services involved, how would you respond to that? I mean, you'd obviously try and get her agreement to it, but if she wasn't in agreement and she said under no circumstances let social services know. How would you deal with that?
I think, in our conversation, I'd have had to become increasingly firmer that a child at risk is tantamount importance, basically, and it would mean that any other concerns are very much secondary to that. So if it's been identified to me that a child needed protecting, if they were, because they're obviously by their nature vulnerable.
Yep.
So I need to safeguard them, and if at the end of it we'd not parted on good terms, and that she was refusing, I would have to explain to her that I have a duty, and I would start the safeguarding process.
And how would you do that? How does that? Do you phone social services directly, or what?
No? I would talk to the hospital safeguarding team.
Okay.
And they would take the investigation forwards. They probably I would tell her that that's what was happening, because they'd be coming to speak to her.
Yes.
As well as then making appropriate contact with the appropriate agencies, visiting the home, and assessing. And it may be that her concerns are entirely unfounded. I'm taking her at her word, but I think I would rather be safe than sorry, and I think safe's the key word here.
But you would go against her
Absolutely.
wishes. You would. Okay.
Yes.
Slightly different. Obviously, we're talking about endocarditis here. Is she at risk of any other diseases and the kind of things that would go through your mind at the same time?
Well, I think there's all of the bloodborne infections.
Yes.
You'd especially if she's sharing needles.
Yeah.
Establish that that she may have shared needles in the past.
Yes.
The more exotic illnesses, perhaps not so much. She's not injecting puddle water or anything like that. But the sharing of needles. So I'd want to make sure that she's screened for HIV, hepatitis, and so on.
Yeah. Good. Slightly different, and just a general point, I suppose, from your point of view. Were you aware of the timings of where you were up to, and in the exam itself, how would you, what do you think you should do? Because clearly you've got 14 minutes in the exam, you get 12 minutes warning that you've got 2 minutes left, and a minute to gather your thoughts. What are your thoughts on how you would keep an eye on that, if you like? Or do you?
I think I haven't been didn't do in this scenario. Putting a watch out would be good, but it may be potentially distracting from talking to the subject. So I think that's something you need to be careful about. In the past, what I've done is practiced doing things for 12 minutes for 14 minutes, and so over and over again, so that you have an awareness of how long 14 minutes is, and that will mean that your timings are a little bit more precise when you're actually in the scenario.
Okay.
I think it's quite difficult to do, but I think the importance of this particular station isn't the timing as it is that the conversation moves along, that patients' questions are answered, that all of the things are detailed, and if there are issues you wish to talk about which there wasn't time for, that's not great. But at the end of the day, I would rather have had an unforced conversation and covered the important issues in a timely manner than to have rushed through something and got through all of the agenda within the 14 minutes.
So in a way, you're suggesting that possibly you don't have to be aware of the time. It's more to do with the conversation, really, and where you're up to, rather than just getting through your own agenda.
Yes.
Yeah.
I think you've got to, your agenda and the patient's agenda have to be coalesced.
Yeah.
And unfortunately, that will mean that some items on your agenda might be missed.
Yeah.
But in favour of addressing the patient's agenda.
Good, well done. And good explanation. What if you finished early? How would you deal with that if you, clearly the examiner, I don't know, maybe even before the 12 minutes or just after the 12 minutes, and you've got another 2 minutes, and the examiners aren't, I don't think, going to speak to you before the 15 minutes is up. How would you deal with that?
I think you've got to treat this organically, and it's got to be as though the patient were there, because they are still sat there. And I think there's nothing worse than 2 minutes of uncomfortable silence.
Exactly.
So at this point, it's an opportunity to summarise what's been said so far and reflect that, to check that the patient understands what's been said, and ask them to perhaps to repeat the salient points of the conversation, and make sure that we've given ample opportunity for them to ask any questions they want to do. I think usually the subjects in these scenarios will have more information that they want to share, and will usually, if asked, do you have anything else you'd like to know, they will ask you something. So I don't think it's not something I would worry about.
Okay. If you truly did come to the end, as some of the candidates will do, despite summarising and maybe asking it, is there anything else? You're worried about anything else? If you truly did come to the end, any advice?
You must maintain the rapport with the patient right to the end. That you can't leave them. You can't simply put your head down and start writing, and then look up and see if they're still there and say, "I said good day." And I think that's important. You must.
So you've got to have a closure. Sort of thing. I think so.
And I think you are, in much the same way that the subject will be an actor, you are an actor. And you don't break character until you're actually talking to the examiner. And I think you will lose any marks for rapport and empathy if you stop talking before the end, or start ignoring the patient, or start making your notes.
I think certainly in that situation, certainly making notes would be a bad thing. However, if you clearly did come to the end, I think closure, but perhaps leaving the door open as well, if anything further comes ahead, is a reasonable thing. And perhaps asking permission to take notes. Saying something like, people say different things, but at the end of it, once you're happy that you have come to the end, saying, if there is anything else, please feel free to ask me, and if I think of anything else, can I ask you? And then most people will say yes, and then just say, I might just make a few notes just over the next minute or so. Is that okay? And they say yes. And you've closed it, but maybe left the door open as well. And I think you're certainly right, as in you don't want to have an uncomfortable silence. But I think, as you say, the majority of times, you can expand it to the time filled. Excellent. Thank you.
Thank you.